Good afternoon. Thanks for the invitation. So I'm just going to present 4 cases. I'll try to get through that in time. So this is my disclosure. The first case is a multiple calcified lesion in the same vessel, stepwise rotablation. So 79 years old, gentleman who had previous bypass operation. He had patent venous graft to LAD, D1, and PDA. However, he didn't have any graft to the left circumflex. He had severe angina symptoms. This is the coronary angiogram of the left coronary system. You can see the calcification there. So the lesion was crossed with multiple specialized wire. I couldn't pass through the midsection of the circumflex with the microcatheter, so I had to park the rota wire there, and I decided to rotablate the proximal section first and then to proceed further. So then after this rotablation, I took a picture just to understand the anatomy a bit more. And following that, I tried to rotablate the midsection with 1.5 burr. It was difficult to cross that with rota burr. And here I had the choice either to change the burr to a smaller size or to do something different. So at this stage, I decided to use Dyna, and I extended the wire further and was able to get the wire down into the circumflex, and that allowed me to get the rota burr down into the vessel. The vessel was then pre-dilated and stented, and this was the final result. So the second case is a tortuous calcified lesion in a lady, 80 years old, who had end-STEMI and recurrent cardiac arrest. So here I crossed the lesion directly with the rota wire. Because of the interest of time as well, she was quite fragile. So I tried it and it worked. So I placed the wire there and performed the rotablation with 1.5 burr, and then pre-dilated and stented the vessel, and this was the final result. So this was one of the gentlemen who is 65 with advanced renal failure with EGFR of 12. He presented 3 times to our hospital, seen by someone else before, and he had declining LV ejection fraction from 45 to 35% after multiple admissions with end-STEMI. And he was reluctant to go for angiogram in PCI because of the risk of dialysis dependency, but eventually on 3rd presentation, he agreed to go for this. So he was pre-hydrated for 12 hours before the procedure, and we carried out the angiogram. So you can see quite significantly heavily calcified mid-LAD and subtotal occlusion CTO of the RCA. So here I decided to first proceed with the right coronary artery and stage the LAD across the RCA lesion with slippery wire and Fielder XT. And then I exchange for the rota wire with the microcatheter and decided to rotablate this. Pre-dilated the lesions and then stented according to the IVUS measurement, and post-dilated the stent, and this was the final result. So I brought the patient back for stage PCI to LAD, and at this stage I took a check angiogram of the right coronary artery, which was looking good. So proceeded with the left coronary system here, crossed the lesion with BMW wire. Here I decided to use IVL and treated the lesion with IVL. So satisfactory expansion achieved, and after that I decided to stent it according to the IVUS measurement. Some under expansions were noted in the stent. Post-dilatation was performed, and IVUS was performed. The IVUS showed stent recoil or under expansion in the proximal section. So here I used OPN to post-dilate further, and then satisfactory result was achieved. So this was a case of 53-year-old gentleman with exertion angina symptoms. And CT coronary angiogram showed triple vessel calcified disease, ejection fraction of 40%. He is diabetic. He declined to have bypass operation. This was the coronary angiogram showing occluded RCA. So the right coronary artery was crossed, rotablation was performed. I was carried out, and according to the IVUS, the stents were deployed. And this was the final result of the right coronary artery. And the IVUS showed well-expanded stent throughout the RCA. So I brought him back for stage procedure of his left anterior descending coronary artery. The IVL was performed. There was quite heavy calcification. After IVL, IVUS was performed to show the calcium cracks. And after pre-dilatation with angiosculpt scoring balloon, the stent was deployed and the stent was post-dilated. And this is one of those results where you get quite smooth stent expansion in calcified lesion. So any questions for discussion?
Thank you very much. Thank you. Thank you. So